Okay. All right, Lisa, I'm ready. Go ahead and ring him in. Hello, Dr. Brown. Yeah, it's Lee Swanstrom. It's good to talk to you again. Thanks so much for taking this call. Thanks so much for taking this call. Really appreciate it. I know you must hate these one-on-one medical director calls. I know I hate doing them. Really appreciate the chance to talk to you about this patient. I think you know who I mean. Hopefully you have his chart, the summary sitting next to you. Thanks for giving me one chance to talk to you one-on-one about appealing his denial. Sure. Yeah, no problem. Yeah, I understand. No guarantees, certainly. Okay. Well, maybe just, I know you probably have his appeal letters and basic medical history sitting next to you, but I wanted to kind of run through things one more time, if you don't mind. So as you know, David's a 37-year-old guy, works for Intel here in Portland, a bright guy, has a newborn baby, and unfortunately he has a 6-month history of difficulty swallowing, regurgitation, bad chest pain, spitting up all the time. His wife won't take him out to dinner anymore. Really kind of a bad situation for him. In fact, when he first saw me, was 6 months history of all this. He'd lost 10 pounds and was pretty panicking. Now it's actually been 10 months because of his denials. As you know, you've submitted multiple times trying to appeal his request for treatment on this, and he keeps getting denied for that. So really pretty rough on this guy. He's a good guy, a critical worker, and as I said, he has bad chest pain. His high-resolution manometry shows Chicago type 3 achalasia. I don't know if that means much to you, but for me, an expert in the field, it means that the best treatment today for him would be per oral endoscopic myotomy. POEM, that's right. Yeah, that's what POEM stands for. Right. Yes, I know that's excluded in his insurance policy. I understand that. That's why I'm calling, to see if I can change your mind. Because I think that's really exceptionally unfair in his case. I think he's an excellent candidate for a POEM. The main thing is this guy is a critical worker at Intel and really can't take time off from work. His employer apparently is a programmer that does this one specific programming, and it's critical. His job can't go on without him, and he's just afraid of taking 2 weeks off work with a laparoscopic halar myotomy. And he's looking, one of his primary things he's looking for is A, relief of his dysphagia, and B, to get back to work as quick as he can. And I think an endoscopic myotomy is tailor-made for this guy. Besides that, he's got Chicago type 3 achalasia, which is uniquely suited for a POEM. Yes. Yes, I'm aware you don't know what Chicago type 3 achalasia is, but we can't really go into that now. I'm happy to send you some papers that describe it, but so anyway, back to his story and why I think he's uniquely suited. One of the powers of, so type 3 achalasia, to summarize it for you, is a panspasticity of the esophagus. So it's not just a disease of the lower esophageal sphincter, it includes the body of the esophagus as well. And the problem with the Heller myotomy in these patients is that you address the lower esophageal sphincter, you don't address their body, their esophagus, their dysphagia may be better, but usually their chest pain is not. And chest pain is one of the incapacitating symptoms that this guy has. How can swallowing be incapacitating? Have you ever gotten a pill stuck in your throat? It doesn't feel very good. Yeah, so take my word, he feels incapacitated. We'll have to leave it at that. Botox? Yeah, Botox in a guy like this, young guy, active, would be ineffective and actually, frankly, be almost unethical to do a Botox. Really, to insist that this guy have a Botox treatment before a definitive treatment would be just kicking the can down the road for his treatment, and as it's a temporary fix. And I know some insurance companies insist that patients be treated with Botox before having a definitive treatment, but I think that's inexcusable. Yeah, that's my opinion too. I'm glad you agree with that. Yeah. Well, maybe, I know you're a podiatrist. Oh, sorry, orthopedic surgeon. Sorry about that. But maybe it would help if I kind of go through the procedure and tell you what it is, because I think one of the key things about this is that this is an approach to a therapy that's identical for whether we do a laparoscopic treatment or an endoscopic treatment. So when we do this, treatment for decades has been a myotomy, division of the circular muscle fibers of the lower esophageal sphincter, and if the body's involved, of the body as well. We do this with electrocautery. We do this under endoscopic vision since the early 90s, and it works great. It's been well proven. When I do this endoscopically, I use basically the same instrumentation and tools. So I use monopolar cautery, it can be a hook or a triangle tip knife. I use a scope, flexible or rigid, it doesn't really matter. And who cares about the acronym, Lap-Heller, POEM, doesn't really matter. I'm doing exactly the same procedure endoscopically that I do laparoscopically, no difference. Yes, flexible endoscopy is different than laparoscopy, that's true, but nonetheless, really the end result of this is a permanent fix for the patient's achalasia. True. There are reports of higher rates of reflux disease after this, and it is a little bit different. Recovery is quicker with the POEM. Reflux disease, and there's been multiple studies about that, show are really pretty equivalent between the two treatments. So not that much difference between the two. And in fact, it's long-lasting. At SAGES, my group at SAGES is presenting a paper, in fact, in Houston that shows our 5-year outcomes after POEM, and shows very good results, equal to laparoscopic treatment. SAGES. Yes, like the wise people in the Bible stories, yeah. Right, exactly. So I think the results are equal. The approach is a surgeon's choice. It's what the patient-physician relationship, it's what I talked to the patient, it's what I recommended in his case, it's what he wanted, and it just seems unfair that the insurance company would step in and say that the patient can't have this. Now, if it was some different drug or some totally out-of-the-box treatment, I certainly could understand that. Yes, I understand there's no randomized prospective clinical trials to date that show that this is a better treatment. Yes, I know your company depends on evidence-based literature to make its policies. I understand that. On the other hand, just think about what I just showed you. There's no difference between these two therapies, and all the literatures have been published. This is an orphan disease, and yet there's been 6,000 or more cases done worldwide, right? Hundreds of papers have been published about it, and yes, they're not randomized clinical trials, but they're good quality peer-reviewed papers, and they all show rough equivalence. So there's actually a couple randomized trials ongoing, one in Europe, one in the United States, but I can tell you my personal opinion is these will never be finished. Why is that? These two procedures are well shown to be almost roughly equal, and a power analysis to show a difference between these two would take thousands of patients in each arm to show a definitive difference. So for this rare disease, we're never going to see a randomized clinical trial. It's going to be definitive on this. Right. Well, I saw your summary of information on that. I saw your summary of information, and I was frankly unimpressed. Your most recent publications were in 2015, and this is a hot topic. It's rapidly progressing, and there's hundreds of new publications that weren't listed in your review. Certainly, I would be happy to send you updated bibliography if you'd like. I'll send you our SAGES paper, our abstract. Good, good. Well, I would appreciate that, and I appreciate you listening to me in trying to get this patient the right treatment that I, as an expert, and he, as a patient, really would prefer having. I think we're not talking about something that's outrageous here. So you'll present it to the regional board of directors. That's great. When is that happening? I mean, this guy is losing weight rapidly. Okay, well, that's good. So I think what we'll do is wait for your response and see what comes of it. Great. Well, thanks again for taking my call. I really appreciate it, and I'll be sure and let Eric know about our conversation. Thanks again. So long. Hey, Lisa, would you mind getting Eric Watson on the phone? I just want to let him know where we're at with this whole insurance appeal. Great, thanks. Eric, it's Dr. Swanstrom. Hey, just wanted to let you know I just got off the phone with the medical director of the insurance company. I gave it my best. I have no idea. Those guys are idiots. Yeah, so we should know pretty quick. They're presenting it to the regional directors in the next week. Hey, listen, I think you and I should really talk, though, about what to do if this is turned down again, because this is really your last appeal. As you know, as we discussed, you have other options. You know, we could do a laparoscopic hilar myotomy. It's a great procedure. I think it would take care of your problem by and large. You might have to deal with chest pain as a separate issue, but at least it would get you eating again and kind of stop this weight loss. Yeah, I know you can't afford to take time off work, but still you need to think about these options. There is one other option that I could offer, and that would be, as you know, I work part-time in France at the University of Strasbourg, and the French has an odd glitch in its medical system that you can have any surgery there for $1,500. And if you wanted to, you could fly to France, and I could do your surgery in Strasbourg, and they let me do whatever surgery I think is most appropriate there. Well, I mean, don't decide, talk to your wife, let me know, and if that's something you want to do, I can connect you with my office in Strasbourg. They can discuss arrangements with that. So laparoscopic hilar myotomy would be perfectly acceptable. Just put up with the time off work, or we can do your surgery poem in France. Great, Eric. It's good talking to you. Sorry I don't have a definitive answer for you, but we'll see. Okay. All right. Thanks. Talk to you later. So Eric, it's been 3 weeks. How are you doing? Yeah, I did okay after that. No major problems. Did you have much pain after your procedure? Great. And eating? Are you doing a regular diet yet? Fantastic. That must make you happy. Is your wife taking you back out to dinner yet? Good. Any bad side effects, any pain, any problems like that? Good. Chest pains are occasional but better, huh? Fantastic. 2 pounds already, that's great. Well, I'm happy to hear that, that's fantastic. So your flight back was okay? Good. Not too much trouble with the baby on the plane? Fantastic. Good. Well, hopefully that was worthwhile. When did you go back to work? 6 days? It's not too bad. So Intel was happy. The world always says, if Intel's happy, we're all happy. Good. Yep. No, I think go ahead and take a regular diet. There's no other restrictions. You should do okay. As you know, at 6 months, we'll bring you back. We'll do an endoscopy. We'll repeat your motility and do a pH test. you are at risk of having some reflux, so we will keep on top of that. Great, so what's the most outrageous thing you've eaten so far since being back? She did. Your wife took a cheese-making class when she was in France while you were in the hospital? Fantastic. And you actually ate her cheese, and it went down okay. Fantastic. Who can ask for more than that? Thanks so much. Let me sit here.
Are mics on? Good. So we'll also take questions from the audience, and we'll kick this off. So Lee, that was truly informative. What kind of patients actually select Heller myotomy over POEM? And you've outlined the potential advantages. What kind of patients go the other way?
You know, it's a funny thing. It's another reason I think a randomized trial is unlikely, is that patients, given the two, and honestly, I love doing Heller myotomies. It's one of my favorite procedures. So I have nothing against them whatsoever. I love doing POEMs too. But patients lined up side by side, even though there's not that much difference, will almost always take the endoscopic procedure. I think it's kind of a mental thing. It reminds me of the early days of lap chole, where you say, well, your bile duct injury rate's 3 times doing it open. I do a little keyhole incision, da-da-da-da-da. Nobody opts for an open cholecystectomy, so very similar.
We can't see mics, by the way, so if you're going to walk up there, let us know. We got a question here? Shout it out.
So for those of you who can't hear, I'm going to repeat the question, which was essentially open chole and lap chole is the same operation with a different access. POEM versus Heller is cutting the muscle minus the fundoplication. What are your thoughts, Lee?
So the thought behind that is if the patient doesn't have a hiatal hernia, they've got their angle of His, they've got their phrenoesophageal ligaments, all their anatomic barriers, their curl impression, all the other associated barriers are there against reflux. And that's probably why you can say they have a high GERD rate of 33% more or less, or you can say that 2/3 of them don't have reflux, even though you do a myotomy, glass half full, glass half empty. But I think 2/3 don't have reflux and don't need any treatment otherwise. 1/3 do, and we deal with that. Almost all those patients are easily treated medically. And as I can't remember if the slide may have fallen off my deck, but all the comparative studies show that a mature Heller myotomy, laparoscopic Heller myotomy with extensive mobilization and a partial fundoplication still has about a 20 to 30% reflux rate at long term. So it's pretty, since you don't disrupt the anatomy, it probably preserves some anti-reflux capability.
Back microphone.
Pete now from University of Iowa. A question about hypercontractility and motility spastic disorders of the esophagus. How are you addressing those with POEM? And if you are, how do you counsel your patients with their post-op expectations?
Yeah, it's a great question. As I mentioned, I think POEM, for those spastic disorders, whether it's DES or jackhammer esophagus or Chicago type 3 esophagus, especially if they have a chest pain component, POEM's ideally suited because it doesn't matter at all where you start that myotomy. It takes about the same length of time. So you can do a long thoracic myotomy and ablate the LES just as easily as you can do, more or less, exaggerating a little bit, but certainly not like doing a transthoracic thoracoscopic myotomy. So I think those are particularly good indications for a POEM procedure because of that. On the other hand, the outcomes, just as they were with laparoscopic or open techniques, aren't quite as good as a routine type 1 or 2 achalasia patient. So we warn the patients you may still have some chest pain. In fact, I tell them you'll probably have a little bit more chest pain for a week or two because we kind of excite your esophagus, and then that should drift off. And usually we'll quote them about a 75% relief or marked improvement of their chest pain.
So Lee, for those patients who really have truly disabling reflux after medical therapy. What's your go-to procedure after POEM?
So we've done a few. We've done almost 350 poems, and of those, I think there's been 4 patients that had such bad reflux that they really had to have something done, 4 or 5. Most of those we offer an endoluminal approach. So either what's called an ARM of Haru-Inoue, a mucosotomy with endoscopic suturing, or if you can get the insurance companies to pay for it, a TIF, it would be a good choice, or even a stretta.
So you can do those.
Yeah.
One thing about follow-up, you mentioned in your talk, or in your story, that 6 months afterwards you're doing routine endoscopy and manometry and pH testing. Kind of take us through that a little bit. How do you use that for treating your patients?
So partly that's an academic exercise. It's actually 6 to 12 months afterwards, but I don't put everybody on PPIs after a poem, since 2/3 of them are not going to have reflux. So I think it's absolutely inexcusable if you don't do a pH study post-Heller myotomy patient, because their symptoms for achalasia are notorious for being unpredictable. So we've shown that exactly 50% of patients who thought they had reflux after Heller myotomy are pH negative, and almost the same 50 that claim to have reflux are pH negative. So you really can't tell by symptoms. So we think that's a mandatory thing. Achalasia patients are always male achalasia patients are at a slightly higher risk of cancer, and we just introduce them to the concept of follow-up screening. We recommend every 5 years, but that's their kind of first introduction. So the manometry is kind of more for our benefit, to be perfectly honest, but a pH and endoscopy is a mandatory post-op study.
For those
Lee.
people that are interested in doing POEM, what do you think the pathway is, assuming that they're a competent upper endoscopist? What do you think it's going to take for people to be comfortable doing that?
Well, I think it has to be embedded in a high volume practice, because if you do 3 achalasia patients a year, it's going to be hard to get over a learning curve. We train our fellows to do it. We've kind of shown a learning curve of about 20 cases. I think a good interventional endoscopist, surgeon that does laparoscopic Heller myotomies probably could pick it up in 10 or 15 cases.
Lee, Dimitri, I just have a question on follow-up of achalasia patients, both post-POEM and post-Heller myotomy. I agree with you. I think there's silent reflux in those patients. We looked at our own data and at 6 months found about a 10% chance of having pH positivity on a probe. It's hard to get, for me at least, my patients back for a pH study. Many don't want to, even for a Bravo. There's some insurance issues. What do you think the role is of upper GI, which seems to be a little bit easier in looking after these patients in the post-operative period? Is there a role?
Yeah, I think time barium swallow, I don't know if I listed it in my preoperative evaluation, but time barium swallow is a good test to follow patients, because patients will end up losing their esophagus if they have progressive dilation. You never have to do an esophagectomy for a narrow type 1 achalasia or type 2 achalasia, but if you let it progressively dilate. So a time barium swallow done well is a good baseline, and it's a good follow-up tool. That's why we add endoscopy to our follow-up, because you can always sneak a Bravo in there while you're doing their endoscopy, and you can use the cancer thing to get them to be interested in having a follow-up screening endoscopy. Okay.
Thank you, Lee.
Yep.
Thank you, Lee.